Hi, this is the Prostate Cancer Lab or Cancer Patient Lab, and this is one of our sessions. We're pleased to have with us representatives from RGCC, who are a testing and diagnostic service, and we'll be learning about the services they can offer to patients. But before we get started, just want to do our standard disclaimers, which are two. One is everything you say can and will be used in a court of law. That is, this is all going to be made public. So if you want to be anonymous, then don't put your photo up, disguise it with some name, or leave now. And then also, this is not medical advice. So this is for information purposes only. If you need medical advice, consult your medical team. We are not practitioners or clinicians or doctors by any means. We are just trying to provide information to people that will help guide their care. Okay, so with the disclaimers aside, turn it over to Chad to do a quick introduction of RGCC and the background for why we're having our session today. Oh, you're on mute, Chad.
Thanks, Brad. The reason I started with RGCC is because I see a naturopath, functional doctor, and I was talking to him about the book How to Starve Cancer and how I was interested in blocking certain pathways, and he said to me that the best way to do that would be to get this RGCC report and actually have some actionable ways to block, certain pathways and to really know properly, because you might be throwing some supplements at, something that really isn't doing you any benefit. So his suggestion was to get this report. And so we did that, and I have developed a supplement protocol from this report that I have quite a bit of confidence in. The other part is I had already been done with my chemotherapy when I got this report, but there's some interesting information that I think they'll touch on that would be very helpful to someone newly diagnosed with cancer. So that's how I started, and basically we'll just turn it over to I believe Lauren to present.
Okay, wonderful. So I'm going to share my screen here. Oh, there we go. Okay, let me bring this down a little bit. Okay. There we go. So we just want to say that we are very excited to be here. And Chad, thank you so much for introducing us to this community. This is an amazing patient-oriented community. And what you're going to find is RGCC is very patient-focused. A very different experience with a lab than you may have had before, but this is something that we specialize in, is helping patients find personalized information so that they can make informed, personalized decisions about their cancer. So this presentation is, we've got a lot of ground to cover, and the overview itself could normally take anywhere between, say, 30 to 45 minutes, but we're going to do a very brief overview because we're doing something very special today, which is taking one of our tests, our most comprehensive test, the Onconomics Plus test, and we're going to do an interpretation demonstration so you can see how the information that you get on your test can be interpreted and utilized to make a very personalized protocol for you as an individual person. And then, of course, we're going to leave time for Q&A. Now, in order for us to get through this information, I am going to ask that questions be held until the end of the presentation, because inevitably there are questions, and if we stop for questions, we won't actually be able to get through everything. So we just want to make sure that we're able to give you all of the information that you need today, so that when you leave the presentation, you'll have information that you can take action on. So let's just jump right in. I'm Dr. Lauren Cohen. I am the Managing Director of RGCC International, which is the US-based branch of RGCC International. We have Dr. Mivin Donato, who is an active practicing clinician He's also an RGCC accredited clinician, and he is also one of the members of our clinical support and training team. And he is going to be doing our interpretation portion of the presentation today. And lastly, we have Panagiotis Apostolou. He's our lab manager in Greece, and he is also a molecular biologist. He won't be presenting today, but he is here so that he can answer as many questions as can be answered, because we do know that you are a community of citizen scientists, and we want to make sure that we have enough staff here to be able to answer any questions that may arise. So our founder, Dr. Yannis Papasatorio, it truly revolutionized the cancer care paradigm. That is his vision. And he is putting something very unique and very special together. He's using CTC testing with a culture of partnership and personalization, which is taking the cancer care paradigm, which is very impersonal, and turning it into something very personalized for each individual patient. CTC testing, or circulating tumor cells, are whole cancer cells that are floating in your system. And utilizing the CTC testing as opposed to biopsy is very impactful. It's a non-invasive procedure. So you basically are able to get the information that you need, the testing done with a simple blood draw. So with a biopsy, it's of course a surgical procedure. It's much more involved, but it also does not provide information in real time, where CTC testing allows you to have information in real time at all times. When you do a biopsy and they preserve the tissue, if they utilize that same tissue at a later point in time during your care, you're using old information. Cancer cells mutate, your physiology is changing, and the expression of the cancer within your body is changing. So utilizing blood draw with CTC testing allows you to stay current with the information of how the cancer is expressing in your body at any given point in time. And also it's done on a microscopic level. So we are not working with medical monitoring that isn't sensitive enough to pick up small quantities of cancer. I call that flying under the radar. So with this, when your cancer gets small enough, medical monitoring can't see it. And unfortunately, if the medical profession can't see it, they can't treat it. So when your cancer recedes to a certain degree, they often will say your cancer is gone, right? But it's not necessarily gone. It's still there on a microscopic level. It just can't be seen. But with RGCC testing, once you get below that radar limit and it can no longer be seen on medical monitoring, you can continue to monitor. So this is a very powerful tool for you to be able to know exactly where you are at any given point in time. So this also answers that question that you often hear in the cancer world for those that were successful with their original treatment is, my cancer was gone, but it came back. And how did that happen? And it happened because cancer cells were still in circulation at a microscopic level, but no one was monitoring them. And unfortunately, it takes for the cancer to grow large enough to be seen again before they're able to intervene. So CTC testing is a very powerful tool and a very convenient tool. The current paradigm in the cancer care world is a one-size-fits-all model. You have a specific cancer type, everybody gets the same treatment. And of late, you're hearing a lot about personalized medicine, but that's really, if you look at the testing that's being done, it's a bit of a misnomer, because the personalization is happening to the cancer. It is not happening in a way that it is personalized to the unique expression of the cancer cells within your unique physiology. And that's where RGCC shines, is the personalization. So the information you get is very detailed and very specific to you. So what makes RGCC so unique as a lab is the personalization and partnership. Okay, let's start with partnership. So RGCC is able to partner with you throughout your cancer journey. With most testing, each lab does an individual test or individual piece, but there is no consistency or cohesiveness through the program. So you go to different labs with different science, with different measures and protocols. But with RGCC, once you're diagnosed and you enter into the RGCC universe, we stay with you all the way through the cancer journey. We help you establish a baseline. We have testing for personalized treatment options. We're able to monitor your progress. And we're also able to monitor once you go into remission in what we call a recurrence prevention program, so that you can, again, be proactive as soon as that cancer is active again. You will know, and you'll be able to intervene at a much earlier stage. Okay, I call this the 3 C's. Okay, the partnership aspect of it provides clarity, consistency, and cohesiveness. So with clarity, you get very detailed, personalized information that you can take action on. So if the information is very clear. Consistency, by staying with the same lab, doing the testing, you have a consistency across the science. Now, one of the things that you may or may not know is that different labs use different science, even for the same test. So if you do a CTC test with another lab, they may be using different science. So you're not comparing apples to apples. So you want to make sure that you have that consistency across each test to make sure that the information is consistent for you. And also having a cohesive program by staying with a lab that is able to support you all the way through your journey. You and your practitioner can put together a clear path for your care. Okay, personalization is power, providing comprehensive, personalized, and actionable information to make informed decisions. One of the things that you don't have is time to waste on treatment options that don't work for you. So we want to make sure that you have the information that you need so that you can make very strategic decisions with specific information that will be appropriate for you. So again, moving away from the one-size-fits-all model into a very personalized approach. So establishing a baseline, one of our premier tests is an OncoTrace test. This is going to give you the cancer volume, the activity level of those cancer cells. It's going to help you measure the effectiveness of your treatment, and it's also going to help you know when your treatment is done. Now, from a patient advocacy standpoint, this test is your most important test. Why? Because this is your yardstick. As a patient, you want to know where you are in your treatment at any given point in time. Is it working? Is it not? So that you can make good decisions and make changes in your protocols as soon as you can, if you need to. Okay, went too far. Individualized treatment options. This is what you may have called the Greek test. It is our most comprehensive panel. It gives you amazing personalized information on exactly what is happening within your cancer and the expression of that cancer within your body. We have 3 different panels, but our most comprehensive is our Onconomics Plus, and that is the test that Chad did, and it's the test that we're going to be doing some interpretation with today. So with our comprehensive personalized information from our Onconomics Plus test, you get information about your circulating tumor cells. You get genetic and physiological expressions such as growth factors, resistance factors, angiogenesis factors, cell cycle regulation, metastasis, drug metabolism and targets, and even radiotherapy and hyperthermia sensitivity, so you know if heat therapeutic options are right for you. In addition, we do chemosensitivity testing on 117 chemotherapeutic agents and targeted therapies, along with more than 53 natural substances, so that when you are making care options, you know exactly which chemotherapeutic agents and natural substances are going to work for you. Monitoring your treatment. Again, you always want to know exactly what is happening with your care. We have 3 different monitoring panels. OncoCount is used for interim only. It just simply provides the CTC testing. But with the OncoTrace and the OncoTrail, it also includes your phenotype and your stemness markers so that you can monitor the activity level of the cancer as it's progressing. This is, again, your most important test because you're going to start with your baseline and then you're going to know where you are. If your CTC is going up, then you know that the treatment options are not working. You need to change course. If it's staying the same, it's working somewhat, you might need to change your options or add something to add a little oomph to your protocol. If the numbers are going down, you know that the care is effective. And with your stemness markers, it's showing the activity level. It's the cancer's propensity to proliferate, to recur, or to metastasize. We want to watch these markers because we want to see them go from positive, which is active, to negative. And you're going to continue on an every, say, 3-month rotation monitoring so that you make sure you are staying on top of the progress and that you can make changes in your care at the earliest possible times when necessary. And then when you do move into recurrence, again, we're able to monitor on a microscopic level. So we have the ability to detect activation of those cells at the earliest possible stages, which puts the power back in your hands so that you can be proactive with your care instead of reactive, waiting for the cancer to get big enough to be seen on imaging and other medical monitoring. Okay, so that was a very brief overview. Now we're going to shift into doing some interpretation. And again, Chad, thank you for allowing us to utilize your test. This is going to be a really interesting opportunity, not only for us to present, but for you as patients to be able to see how this information is utilized. So I'm going to turn the presentation over to Dr. Mivin Donato, and he is going to continue on with the interpretation.
Thank you, Dr. Lauren. Let's go ahead and advance the slide. So the Onconomics Plus test results consist of 24 pages. And so the most important thing to remember is this is the test that provides all the information you need to determine what is effective therapy for the cancer, for whatever cancer that is tested. And so the therapeutic options that one will obtain from this test is pretty much covers a broad number of different therapeutic approaches. There's chemotherapy, and the chemotherapy, of course, it provides the most effective therapy for this particular cancer cell, and then of course there's the targeted therapies. Okay, that's the monoclonal antibodies and a small molecular weight, and then there's the radiotherapy and hyperthermic treatments. So those are, selection depending on what's considered high sensitivity, and you want to utilize only the ones that work. This basically removes the guesswork of what is effective. And then there's the off-label drugs or repurposed drugs. And then there's the natural substances. And there's 53 natural substances that are routinely tested. And so those are what the practitioner can select as the strategy is created for therapy. And so go ahead and advance. Next slide. Okay, so you're looking at several, there are several pages. This is page 2. And so what you're seeing here is that when the specimen arrives at the lab, and once they have isolated the circulating tumor cells or CTCs, and you can see here the CTC count is 4.2 cells per mil with a standard deviation plus or minus 0.3 cells. So if this is the first test, then this would constitute the baseline, which is 4.2. And for prostate cancer, there's a statistical cutoff of less than 20 cells per mil. And so if this is the first time this person has had testing and there's no treatment yet been rendered, then this would constitute a relatively low load of cancer, or it would be considered early disease category. And so there's no staging like conventional stage 1, stage 2, stage 3 to stage 4. It's basically a cutoff where is it less than 20 or is it greater than 20? So that would constitute an advanced disease if it's greater than 20. And it's in this case, it is an early disease for this category. And as far as the isolated cells, once they're isolated, they're expanded or grown in the lab so that one part can be tested for chemosensitivity test, which is the viability assay. And the other group goes for transcriptomic microarray, which is the RNA transcripts and determine their expression rates of these genes. And so by doing that, it provides the practitioner the ability to create a very specific target so that it is very personalized for this particular case. And so not only will you select the correct agent that will either destroy or that will inhibit the growth and at the same time modulate or the immune system, it will also provide specific way to determine how you can target a specific gene that's overexpressed. These are the validated cancer genes that are overexpressed, and they can be either inhibited in its, the receptor can be blocked, or it could be interfered in the metabolic pathways. And so this is where the practitioner will be able to narrow down into a very specific treatment that will be effective without having to guess what will work as in a group setting, which is typical in a conventional system. It's not personalized. And so go ahead and do the next slide. So this is an example of defining specific targets. So with the gene expression, these are the validated tumor-related genes. In this particular case, you're looking at these blue bars that are going to the right. That's an overexpression of the genes. And if it's going to the left of the line, then that's down-regulating. So in this particular case, the IGF receptors 1 and 2 are overexpressed. And so these are insulin growth factor receptors that when they're overexpressed, for the CTC or certainly tumor cells, it would mean that any insulin surge due to consuming carbohydrates, anything that causes an insulin surge, particularly high glycemic carbs, will cause these receptors to grab the insulin, have it increase attraction to the insulin, and then of course that brings the sugar or nutrients into this cancer cell. And so that's one way to help proliferate or grow the cancer. The other thing here is the NR3C4A and NR3C4B. These are the androgen receptors, the hormone receptors. And so when they're overexpressed like this, there's no question that this is a hormone-driven cancer. And so one of the things that is conventionally done is you want to get a hormone blocker or hormone blockade. And so this is where drugs like Lupron, which is an injection infusion, is given to the patient because they're trying to block the hormone. But you have to realize that there are 75 validated tumor-related genes. So you can't block everything. You're going to block only some of them or one or two, which is common in conventional practice, but yet all the other genes are still overexpressed, and it's causing the cancer to proliferate. That's why you cannot just destroy the cancer completely. The more genes that can be blocked or interfered in terms of the growth, that's when the therapy becomes more effective. So this is where the clinician can really make a difference when they are specific and able to block as many genes as possible. On the right side, you see the downregulation of the heat shock protein, and these are the ones that, when it's downregulated very high, then it means that these cells do not have tolerance for heat or hyperthermic treatments, and so they get destroyed very easily compared to the healthy cell, which is going to be 0%. So when it's downregulated this far, you can be sure that radiotherapy or hyperthermic treatments will work really well. Next slide. The RGCC test, anatomic test results also shows the resistance to therapeutic agents. And so these CTCs have characteristics that make them resistant. And one of the things that that's not featured here, which is the OncoTrace test, which is done always with a baseline Onconomics Plus, is that it tells you already from the phenotype that these are resistant type cancers, and everyone's going to have different resistance phenotype. And so in this case, this is a MDR1 is the multi-drug resistance factor, and then there's the MRP, which is the multi-drug resistance protein associated, and then the LRP is the lung resistance protein, and the GST is the glutathione S-transferase. So these are different aspects of resistance to therapeutic treatments that the cancer cell exhibits. And so one of the things that we do is we determine if it's a high resistance in this case, then we would customize the therapy to get around this resistance barrier. And one of the things we do is to determine the frequency of exposure to the CTCs using a therapeutic agent, because the higher the resistance, the more likely this will develop secondary resistance in a very short time. And usually it's between 4 to 6 months. You already see ineffectiveness developing, and the CTCs are no longer decreasing in a steep dive. It starts to plateau. So that's when you know it's no longer effective, or there's resistant clones forming. And this is basically the feature of the high resistance subpopulation of CTCs. And there are many different populations. Just bear in mind, this is not a homogeneous population, it's heterogeneous. And it's that small segment that is what the chemotherapies cannot destroy. And they end up being the MRD, or minimal residual disease, which basically represented well in this subpopulation. So we would rotate the agents more frequently. That's one of the things that will help. And at the same time, we use certain agents to help reduce or increase the sensitivity to cytotoxic agent. And when we add these agents in, it overcomes the barrier of resistance. And the GST, again, that's has to do with the glutathione, or elimination of the as far as detoxification, and that is what some people have a very high GST, which means that it's able to eliminate the cytotoxic agents effect faster, and which means that the person will not get the therapeutic benefit compared to if it stayed and have more effect on the cancer cells, because they're able to basically detox themselves. Next slide. So here's an example of a chemosensitivity results, and RGCC recommends that we get we recommend, or they would recommend to use or select the high kill rate. So this is expressed in percentage, which is sensitivity or high kill rate. And this alkylating agents is a portion of it was taken, and it shows here that we've got 3 alkylating agents that shows over 80%, 80 or above. And so that would mean that those are the 3 agents that would be recommended to be selected as a high sensitivity. And that would mean the residual disease is a lot less, or you're talking 18 to 20% MRD or minimal residual disease, because you don't want that residual to be high, because it would cause a problem down the road as they start to increase in their numbers and much more difficult to destroy. So you want to have high kill rate, low MRD, and so that's the group. There's different categories or classes of chemo drugs, and this is just the alkylating agents. Next. So in this particular one, we're now looking at the sensitivities for the natural substances. And class 1, which is cytotoxic agent, we're looking here at a percentage that's based on 1 dose, whereas the other, the previous slide, it was based on 6 doses in 6 days. This is basically 1 dose, and then they determine the efficacy. And you can see here that ascorbic acid, which is the vitamin C, has a very high efficacy at 40%. The threshold is 5%. Anything above that would be considered sensitive, but we tend to recommend more of the 15% or higher to start. And then we basically, as we rotate the agents, we start to get lesser, the lesser ones, because we want to target the cancer at the most effective agents, because that first 6 months is crucial, because secondary resistance starts to develop. So we only utilize the most effective agents first. Next slide. So this is a class 3 protein kinase inhibitors. And so with this, it's a very broad effect. You can see it's inhibiting the EGFR, which is the epidermal growth factor receptors, the IGF, the insulin growth factor, and then the VEGF, PDGF, FGF. These receptors are angiogenesis. So, one of the things that commonly done in oncology is they select an anti-angiogenesis drug, because cancers mostly have overexpressed angiogenesis because of the need for increased blood supply and nutrients. The signal transduction pathways can also be blocked. And so this group of agents have a broad effect. And so this is usually looked upon after they looked at the gene expression rates. We find the areas here that we want to use to block certain genes. And so curcumin turmeric shows high efficacy. And so we would definitely select that. Again, 5% threshold, anything 15% or higher is what we'll select as the first ones to use. And then we rotate them through the year. Next slide. Okay, back to you, Lauren.
Thank you. So what we want to do is leave a lot of time open for questions and answers. Just want to let you know this is an international lab. We do have branch offices and independent distributors around the world. In order to get RGCC testing, you do need to be connected with an RGCC practitioner. And since this is a worldwide audience, we are going to direct you to the contact pages, because not all of the people in your audience will be connected with our branch. So what I suggest that you do is you go to rgcc-international.com. In the lower right-hand corner, you're going to see a purple button that says order a test. Just click on that button. It will take you to a page where, if you are a registered clinician, if you're interested in registering as an RGCC clinician, but also right here is I am a patient. When you click on that link, it will take you to a contact form. Your information will be sent to our main office in Switzerland, and then it will be redirected to the appropriate branch office in your region of the world. And now we're just going to open it up to questions and answers. I'm going to stop sharing for the moment. There we go. And we can always bring that slide presentation back up if there's something specific. So, Brad, I'm going to kind of allow you to manage the various questions, and our team is here to to address them.
Thank you. That was great. That was a great overview. I really appreciate it. And it inspired me to, I want to click on that purple button. I think what we'll do is what we try to do to manage this is if people could use the raise hand feature. If you have a question, we'll use that and I'll call on people with the raise hand. But I'd like to give Chad and first a chance to just share with that presentation a little bit of the value he's received. One of the ways that we work, just for the folks at RGCC, is we have a pioneering patient like Chad who runs into a service provider, tries it, has an experience. They're like a secret shopper, and then they recommend it, and then they recommend it to others, and then more of us take it up. And for some of the service providers that we've found, we say we recommend all of the patients get this test. So we have that relationship with a handful of companies, somebody like MProbe that does proteomics, for example. And so, you're on that pathway to recommendation, but it really starts with Chad and sort of the peer-to-peer review that he would give of your services and how he's found value with it. So I'd like to start with Chad and just sort of say, you were introduced to this through your integrative oncologist. You got the test. What's your kind of candid review of the value you've received?
I have some confidence in my supplementation program now that I am blocking pathways. Like angiogenesis was identified as being highly upregulated for me. So, for me to try to regulate that now is very important. So I think I found some benefit of that. Like I said before, I had already received chemotherapy and was already deep into my treatment plan when I did this. Had I done it early, one of the things I find very interesting is they have a conclusion at the end of the report. And one of the conclusions I found, I have a very upregulated overexpression of MDR1, which is the resistance protein, or the resistance. And it says here, the specific tumor appears to have resisting populations because of MDR1 overexpression that can be reversed by the use of inhibitors of ABCG2 pumps. So if someone could address what that means, I think that's an interesting thing that we can kind of allow the chemotherapy agents or whatever to work around that resistance a bit. I think that would be important for any of us deciding to do another round of chemotherapy. So that one is interesting. And then I also have a question about the reoccurrence resistance program. That seems interesting. And what does that look like? I mean, what are you doing? What is RGCC doing for that program? So a couple of questions to start with.
Gotcha. So the first question, Mivin or Panos, I'm not sure which one of you would like to field that first question. And Chad, can you repeat that first question?
Yeah, the conclusion says that we could reverse the overexpression of MDR1 by the inhibitors of ABCG2 pumps. So I was wondering what that looked like, how that would work to inhibit that.
Well, I can first answer that portion. The inhibitors that we use are flavonoids is one. And that what happens is when you're using flavonoids with cytotoxic agents, the presence of flavonoids will help to increase the cancer sensitivity to the cytotoxic agent. And so that's a sense of overcoming that barrier of resistance. And so that's an ABCG2 pump inhibitor. There are off-label drugs that are used, like certain antifungal drugs like ketoconazole is one, but that's not what we emphasize. We emphasize the natural options or the natural substances to help improve that sensitivity. So it does reduce that resistance. And then, of course, the rotation of the timing of the agents are important because we want to make sure that the agents remain effective, because over time the cancer cells are mutating and they're becoming less and less sensitive to the agents. So those are the combination that we work is to help address that barrier. And then what was the second question?
The second question was about the remission and the recurrence prevention program.
Yeah, so you will reach the remission level is when your numbers are very low to 0 to 1, basically. That's kind of a remission status, and that's on the CTC. But you also have to make sure that the phenotype markers are also negative or very close to negative, dim or negative. And then you have to also, that's actually more important because the subpopulation, which are the ones with the tumor stem cell markers, they're the ones that drive the disease. So if you don't look at the phenotype markers and you just rely on the CTC number, sometimes that's misleading because when the CTC number starts at a certain level and then it's going down, if it's not yet down to that 1.2 or less CTC, you still have that high risk of metastasis because you haven't addressed that small segment of population. They're the last to go. So when the CTC number are decreasing, you're actually destroying the weaker cells, the ones that are not as strong as the dominant ones that are only a small segment of that CTC. So you have to pay attention that subpopulation is very important. And you can only see that on the OncoTrace and the OncoTrail tests as you monitor that. And once you reach that 0 to 1 level, which is pretty very low risk or remission level, then you just monitor it once a year to make sure that it's not coming back up because of some changes in the internal environment of the cancer. Maybe the gene expressions are starting to overexpress again. And so that's when you can early detect the change and then address it right away.
Right. And I want to add a little something to that in terms of the recurrence prevention program. And then Panos, I have a question for you that came up in the chat. So as long as there are CTCs in circulation, right, we're able to actually run the Onconomics Plus panel, and you're able to see what you may not be able to do chemotherapeutics. Again, if they can't see it, they can't treat it, but you now will have all of those natural agents that you could utilize to continue to support your system. So along with, monitoring just to make sure that those stemness markers don't reactivate, because again, you can have a very low cell count, but if that low cell count is still active, your care is not done. But then once care is done, they do go into the negative, so they're no longer active. You want to continue to monitor, but you also still have information on what natural substances and therapies could you potentially use to continue to support a non-cancer environment. Okay, so Rick, you actually have a question here in the chat, and I'm going to hand this one over to Panos. And the question is, I'm a little surprised that you used microarray technology. Is that because of low volume of sample? Why not use NGS?
So as we discussed, we have many different labs. They may use different science protocols and different techniques. So in our case, we use microarrays since when we started in 2004. And of course, we also use NGS. So we try to make some validation to see what is more effective. All the techniques have pros and cons. So microarrays is okay and very well established and well-known technique. NGS is the new area that came the last years. So still some issues need to be, we have to face some more things that we need with NGS, but it's not the low volume of sample. On the contrary, the NGS need much more lower quantity. The microarray that the platform that we use, first of all, enable us to study the whole gene expression profile. Also, there are platforms in NGS that they can do that, and we have tested them, and we have seen that the data are comparable, so we do not have statistical significance. It's really important with microarray and the platform that we use that we can test several samples in parallel. So imagine that we can have a few dozens of samples tested per day. It's also feasible with NGS, but it's really more dedicated. You need more expensive equipment, so it changes the platform. But definitely, yes, we have compared the results of microarrays with NGS, and it's really important that all the assays that we use are accredited. So we have validated with other labs, with other techniques to make sure that the data we provide are accurate and comparable if they're using the same technique.
You use Affymetrix.
The one we have used also Affymetrix, but also we have a supplier that provide us customized printed slides. So one slide for all the gene expression profile, more than 180,000 probes.
Thank you.
Okay, and I do see another good question in the chat from Robert. None of us, I believe, are newly diagnosed or heavily and have been heavily treated. How would that affect which test to use and when to use it? And it actually doesn't affect which test. So, in an ideal world, we would, you would know about RGCC as soon as you got diagnosed and you can step into the system before you start treatment. But the reality is most people have gotten treatment before they find RGCC. And hopefully that will start changing as, we begin to expand and people become more familiar with, with RGCC testing. But whether you are newly diagnosed or you have already been treated, you still step into the RGCC universe, right? We call it our family into our community, and you start with the testing in the same way. So you would start with your OncoTrace to establish your baseline. You would then go into your onconomics panels, and then you would continue to monitor, and then also into remission. So there is no difference whether you are newly diagnosed or you have already been treated. You would still follow the same process, the same procedure, the same formula that we have. And our system, so our system is open to, patients in all aspects of their care, whether again, newly diagnosed or you've already been in treatment and you're looking for new or additional options.
Okay, Robert, did that cover, I know you have your hand up. Did that cover, do you have any additional questions, or did that answer your question?
No, actually, I do have additional. So one is, and someone put in the chat about the cost and insurance coverage, Medicare coverage.
Mm-hmm. Yes, so at this stage, none of RGCC's tests are covered by insurance. That is something that our team is working on. Again, this is outside of standard of care. And as you know, that when you step outside of standard of care, if you move into the integrative and natural care spaces, unfortunately, much of that is not covered. It is, either cash or out of pocket, depending on what you do. We do have price sheets that, as well as the cost of the tests, of the various tests, are listed on the website. When you go into the website, you click on each individual test, scroll down to the bottom of the page, and you'll see the pricing listed in euros. So depending on what region of the world you are in, you may have to do a conversion, right? So if you're in the North America region, we already have that for you. We have a price sheet listed out that has all of the prices in euros, and then an estimated conversion rate, because it does vary, based every day, the conversion rate changes. So it gives you an approximate in US dollars so that you have a sense of what that is. But again, because this is an international audience, US dollars may not make so much sense. So you would do your conversion from euros into whatever currency you have in your part of the world. And
just could we get Chad, could you say how much does it cost you? Just give people a ballpark sense of what we might be looking at.
I think the test itself was right around $2,000, and then there was some consulting with the doctors prior and after, so another, $750. So it was reasonably expensive, and now I think next month I'm going to do the follow-up, so I'll be doing another round to see where I'm at. So.
Right, and just so you know that the different tests all have different price points. So, so the Onconomics Plus is one of our more expensive tests. where the OncoTrace is at a lower price point. So it's not that each test is there, but there, but again, with the pricing that's either on the website or, if you are able to reach out to us, we can provide you with that price, the price sheet. And keep in mind that those are prices for the testing. It does not include in-office fees like consultations and blood draws and, those types of things. There would be additional fees that the practitioners themselves would ask for.
And just a question along those lines, Lauren, to what extent do you think that patients would be able to get the test? Because you do have a direct-to-patient option, like I'm a patient and I want the test. Are they able to make sense of the test themselves, or do you find that they need an integrative oncologist or some kind of practitioner to partner with them to interpret these 24 pages of results?
Right. We do not offer direct with patient. In order to receive RGCC testing, it is essential that you get connected with an RGCC practitioner. We only work with RGCC registered practitioners. So even if you have, say, a naturopath or a primary care physician, they can't just order a test. And again, this is something a little bit different about our lab, is that you can see the complexity of the information on this test. So we have something called RGCC College, and all practitioners must go through our training so that we can ensure that you as a patient are going to be matched with a practitioner who is versed in interpretation and how to take that information and turn it into a personalized protocol for you. So instead of, so the answer is, you can see the complexity. If, let's say that you do get the test somehow, right, someone is willing to just run the test for you, you just get that report, it's going to be impossible for you to interpret it. And that's why we have, the training that we do, because we know how important this is. And I want to kind of stress something, that both my mom and sister are active stage 4 cancer patients. So when I speak this, I'm speaking this actually from the patient side, that you want to be paired with someone who is fully versed so that you can use the information in its most powerful way. You don't want to be misinterpreting or delaying time trying to interpret a lot of information that doesn't make sense. And I don't know if, and I think Chad may be one of the only people in this community right now that has done our testing, but we have had patients where they take their panels, they even walk into their medical oncologist and they have no idea what they're looking at. Right? It's not a standard test like a CBC with differential where everybody knows how to interpret that kind of information, or, basic information. It's very complex. It has a lot of nuance to it. And we want to make sure that you are paired and partnered with a practitioner who is going to be able to really work with you so that you get the most impact from the testing and the information.
I think that's great advice. Thank you, Lauren. That's very clear about access and interpretation. I'll just mention that the members of our community are often in that boat, that they've got an RNA-seq test or they've got a proteomics test, and their treating physician has never seen an RNA-seq report or a proteomics report. And so they're having to educate their clinician in the course of trying to say, I think this is what this means, and I think this is what I need, but they're having to bring sometimes treatment options. So we're used to being in that boat, is I guess the point. Jonathan, you have your hand up.
Yeah, well, this is a sort of a general thing. You said this report was about 20 pages or 24 pages long, and we only saw like 3 or 4. I mean, what are we missing? And do you determine, when you recommend flavonoids or metformin or anything else, carboplatin, are you recommending dosages and treatment protocols? Or is that just is this all you're doing is showing the presence of these different things and leaving it to your RGCC physician to interpret it? But my guess is you're going to say the latter. But I'm also wondering what didn't we see in all those other 20 pages?
Okay, well, there's a lot to cover, but basically you only saw the insulin growth factor receptors and the heat shock proteins and some growth factors, but the ones that you were missing are angiogenesis, signal transduction pathways. You're missing information about cell cycle rate, which is how fast the cancer is growing. And we checked, there's 3 main genes that control that cell cycle rate: the P53, P27, P16 genes. And then you're also missing the metastasis genes that are overexpressed or downregulated depending on the situation. And so that tells us how much risk there is involved in metastasis for this particular cancer. You're also missing information of certain genes that are overexpressed that may be effective to find a targeted drug for it. And for example, the CDK4, CDK6, as in certain cancers like breast cancer, then usually you'll locate in the next few pages a targeted drug to see if there's effect to it, such as palbociclib, which is a CDK4, CDK6 inhibitor. And so, you're able to match up the chemosensitivity and the gene expression rates to make sure that it's effective. And then the other thing is that you're missing also is the longevity of the cancer, or is it the kind of cancer that's going to be there for a very long time? And that's the HTERT gene. And so if it's highly expressed, you're looking at something that is not going to go away. It's not unusual to see a high expression HTERT for a cancer that was diagnosed back in 2004, a prostate cancer, which I have a case like that, where it's been around since 2004. It hasn't yet been, this person is not in remission, but it's more like living with cancer. Okay. And so there's lots of information to cover, and then we create a strategy in how to address all those overexpressions and how can we downregulate them, and not just depending on the chemo sensitivity, although the chemosensitivity really takes precedence over the gene expression rates, because you're actually looking at the reaction of the CPCs to these agents. And that's what gives the RGCC physicians the ability to be selective to the one that works, rather than trying to go through the guesswork, which is typically what is seen in conventional oncology, relying on statistics of group diagnostics and determining what fits according to the FDA from the clinical trials. Well, we don't do that. We determine what will work for you rather than what could work for the group, because there's going to be some ones that not going to work for them because it's just their CPCs are not responding to that drug. Well, you're not going to be guessing when you're doing RGCC testing. It removes the guesswork.
Mm-hmm.
Jonathan, are you okay?
Well, I'm curious about, Brian just sent me a direct mail. How are you measuring patient success from your treatment recommendations? Or do you have any data on if someone chooses something that you guys have recommended that is not standard of care? Do you have any data on what the outcomes have been?
I can tell you one thing: if you're not working in a standardized format, everything is not going to be comparable to another person, just like a fingerprint. So we look at the baseline first, which is the OncoTrace test. And then what we do is we determine if the response to treatment is good for that particular person. And then we make adjustments as we check this quarterly. So you can't really say, it's not really easy to just create a group average, because everyone is so different. Some people get sick easily and some people don't. So how in the world can you create a very good slice of a group of people when they're all different? That's where the problem becomes an issue. So really, we look at cases on an individual level. How are you performing in 6 months? And that's why some people are doing very well because they respond really well to therapy and some don't. Well, we minimize that non-response by determining what will work for this particular patient. See?
Yeah,
So-
I get your approach, and it's a very innovative and ambitious approach, and I hope it works well.
Very
I'd just
expensive.
be curious to get some actual documentation of results. Now, like, let's say for your flavonoids, okay, how would you determine a dosage for that?
The RGCC does not tell us the dose. This is based on what information we have to apply it to the clinical level, from a scientific level to the clinical level. So there is, over time, since it's been around since 2004, we've created pretty much a data for physicians as a typical starting dose. And so there is a general guidelines, what's been done before, so that we will know typically how much to start, and then they kind of work up from there. It depends on the physician's experience. But no, we're not given specific dose. There's a recommended dose, but that's from the clinical aspect.
I'm, as the process facilitator, I'm going to stop the recording now.